Unstable angina. Classification chronic coronary syndrome scale CCS scale causes of unstable angina, short notes on cardiac biomarkers, pregenital angina, warm-up angina, syndrome X, silent ischemia, perfusion imaging, infarct size reduction, vulnerable plaque, IPC and POC, ischemic cascade, viable myocardium, cardiac remodeling, hibernating myocardium, stunned myocardium, MVO, MINOCA, metabolic syndrome, high sensitive CRP, coronary artery disease in women. Now, unstable angina. Unstable angina means rest angina or angina with minimal exertion lasting at least 20 minutes. New onset severe angina occurring within the last month. Crescendo angina, previously diagnosed angina, become more frequent, longer in duration, more severe. At least one CCS class increase or at least CCS class 3 severity. Now, Braunwald classification of unstable angina. In terms of severity, there is three classes: class 1, class 2, class 3. Class 1 indicates new onset or accentuated angina, no rest pain. Class 2, rest pain within the last month but not within the last 48 hours. Class 3, rest pain within the last 48 hours. In terms of clinical circumstances, it is also three types: class A, class B, class C. Class A means develop in presence of extracardiac condition that intensifies myocardial ischemia such as anemia, prolonged tachycardia, hypertension. It is type 2 MI এর মতো. Class B unstable angina means develop in the absence of extracardiac condition. Class C unstable angina means develops within 2 weeks of AMI, within 2 weeks of acute myocardial infarction, that is post-infarct angina. Now, Canadian Cardiovascular Society Angina Scale, CCS scale. CCS classification or angina scale is the most commonly used system for grading angina severity. There are four classes. Class 1 indicates ordinary physical activity does not cause angina. Example, walking, climbing stair. Angina occurs only with strenuous, rapid or prolonged exertion. Class 2, slight limitation of ordinary activity. Example, walking uphill, climbing stair after meal. Angina, walking more than 2 city blocks or walking more than one flight of stair a few hours after awakening. Class 3 angina means marked limitation of ordinary activity, that is angina occurs during walking less than one city block in level ground or climbing one flight. Class 4 angina means inability to perform any physical activity without discomfort. Angina with minimal activity, also at rest. Now, importance of CCS angina scale. 1. It is positively correlates with number of diseased epicardial coronary arteries in coronary angiogram. Impaired LV function, need for revascularization such as PCI or CABG. Predict outcome in patient with chronic coronary artery disease, major impact upon quality of life. What is the drawback of CCS scale? Inaccurate in diagnosis of coronary artery disease in patients who do not repast chest pain, sole symptoms other than chest pain. Angina equivalent. Now, causes of unstable angina. What are the causes of unstable angina? 1. Non-occlusive thrombus on a patient on a pre-existing atherosclerotic plaque, most common, that is non-occlusive thrombus on a pre-existing atherosclerotic plaque, most common. Dynamic obstruction by focal spasm, prismatal anginas. 3. Secondary precipitant of myocardial ischemia such as fever, thyrotoxicosis, tachycardia, malignant hypertension, pheochromocytoma, aortic stenosis, high output state, pregnancy, drug like cocaine, amphetamine, reduced oxygen supply due to anemia, hypoxemia, carbon monoxide poisoning, polycythemia rubra vera, hyperviscosity syndrome. 4. Causes of unstable angina: mechanical obstruction, that is restenosis after PCI without spasm or thrombus, arterial inflammation and or infection such as coronary dissection or vasculitis, spontaneous coronary artery dissection, particularly younger female patients, example pregnancy. Type of coronary dissection: there are 6 types of coronary artery dissection. They are A, B, C, D, E, F. A indicates luminal haziness, B linear dissection, C extraluminal contrast string, D spiral dissection, E dissection with reduced flow, F dissection with total occlusion. Treatment: if stable, observe plus minus GP2B3A receptor antagonist. Type A or B. For type A or B of coronary dissection, treatment is stenting. For type C to F, try stent if wiring into lumen is not possible, and if vessel size is more than or equal to 2 mm, then CABG. If vessel size is less than 2 mm, then medical management or anti-anginal management. Now, cardiac biomarkers. These are intracellular enzyme or protein released to blood following cardiac muscle damage due to ischemia, example MI, or other assault, and shows serial changes in plasma concentrations with an initial rise or fall followed by fall. Characteristics of ideal biomarkers: it is cardio-specific and high concentration in myocardium, highly sensitive, normally absent or present in trace amount in blood, rate of release is proportional to extent of damage, stable and persist for a reasonable period of time in blood, early to measure and inexpensive. Clinical use: for diagnosis of MI, for prognosis, for risk stratification. Types of biomarker: enzyme, AST, CK, CPK, LDH. Other protein: troponin I, troponin T. Myoglobin. There is also troponin C, that is calcium calmodulin. Troponin T and troponin I. T means tropomyosin, troponin T means tropomyosin, troponin I means inhibitory components. Now, kinetic behavior of cardiac biomarker. Myoglobin: initial rise after MI 2 to 4 hours, time to peak 8 to 12 hours, return to normal within 24 hours. Myoglobin return to normal within 24 hours. Troponin I: initial rise after MI 4 to 6 hours, time to peak 12 to 24 hours, return to normal 5 to 10 days or 7 to 14 days. CKMB: initial rise 4 to 6 hours, time to peak 12 hours, return to normal within 2 to 3 days. CKMB return to normal within 2 to 3 days. Troponin T: Initial rise after MI 4 to 6 hours, time to peak by 48 hours, return to normal 10 to 15 days or 8 to 21 days. Now, new cardiac marker, ischemic modified albumin IMA. Ischemic modified albumin IMA, myelomonidase, glycogen peroxide, super soluble urokinase type plasminogen activator. Now, variant angina or prinzmetal angina syndrome characterized by angina at rest with transient marked ST segment elevation. Nature of attack. Attacks were cyclic in nature. Attacks are cyclic in nature. Prinzmetal angina or variant angina attacks are cyclic in nature, often occur in each morning. ST elevation disappears rapidly as the chest pain reduced. Caused by coronary spasm, usually focal and after at the site of coronary artery stenosis. Usually focal or after at the site of coronary artery stenosis. Underlying coronary lesion vary, mild to subtotal stenosis or normal angiographically. Pathophysiology of prinzmetal angina. Abnormalities in endothelial function and nitric oxide activity. Abnormalities in endothelial function and nitric oxide activity. Reduced nitric oxide activity. Imbalance between endothelial derived returning and relaxing and contracting factor may contribute. Imbalance between endothelial derived relaxing and contracting factor may contribute. Clinical feature. Clinical feature of prinzmetal angina, young patient, heavy smoker, no significant risk factor for coronary artery disease, history of migraine headache 25%, history of migraine headache 25%, Raynaud's phenomenon 25%, syncope during rest angina due to variable arrhythmia or AV block. Potential consequences of variant angina. MI with prolonged spasm, ventricular arrhythmia, AV block, sudden death. So, potential consequences of variant angina, there may be MI with prolonged spasm, ventricular arrhythmia, atrioventricular block, sudden death. Now, diagnosis. ECG ST elevation during attack and disappear promptly after GTN administration. Cardiac enzyme normal. Holter monitoring or event monitoring. ETT provokes angina with ST elevation in 1/3 of patients. ETT provokes angina with ST elevation in 1/3 of patients. Provocative testing for confirmation. Cold pressure response, exercise, argonovine, acetylcholine, CAG, coronary angiogram. Other ECG manifestations: T wave inversion, increased amplitude, QRS, increased R amplitude with diminution of depth of S wave, intraventricular conduction defect. Treatment: difficult to treat. Fate, spontaneous remission is common. MI common within first 3 months of diagnosis. GTN sublingually, relief pain within minutes. Long acting nitrate effective. Calcium channel blocker with higher dose. Nifedipine 90 mg per day. Diltiazem 360 mg per day. Verapamil 480 mg per day. Amlodipine 20 mg per day. PCI CABG if significant stenosis present. Statin therapy beneficial effects on endothelial dysfunction underlying atherosclerosis. Walk through angina or warm-up angina. Walk through angina or warm-up angina. Appearance of anginal chest pain or discomfort early in the course of exertion which subsequently subsides despite continued exertion. Pathophysiology of warm-up angina. The precise mechanism is unclear, maybe due to an initial increase in coronary vascular tone with a consequent reduction in coronary blood flow at the beginning of exercise. Recruitment of collaterals may also play a role. Ischemic preconditioning by adenosine, bradykinin, opioid receptor activation. Treatment same as chronic stable angina. Significance of warm-up angina. Patient with stable ischemic heart disease is able to increase his or her exercise tolerance following an episode of angina followed by a period of rest. Heart is able to protect itself with brief episodes of ischemia as a phenomenon of ischemic preconditioning.